Hi, this is Dr. Alice Lee. Welcome to iCubed. iCubed is EMN's latest blog, and we're really excited that you've joined us today. Every month I will have a guest, and usually a colleague of mine, and we'll talk about a case, a real case that I have. And we'll go through it like a curbside consult, or maybe having some pizza or coffee with your friend. We're just chatting about these cases, and hopefully we'll all learn a little something and inspire each other to really pursue excellence in patient bedside care. So this month, my guest is a fabulous ER doctor, and I love her to death. So why don't you introduce yourself?
Why, thank you. I paid you well.
Yes.
My name is Mary Katherine Harper. I did my residency in Kingman, Arizona. And upon graduation, I stayed on for 2 years as faculty and the assistant residency director before coming down to the Phoenix area.
Yeah.
And since then, I have been the assistant medical director, and now for 7 months, the big girl now,
Yes.
I am the medical director for Banner Baywood. So thank you for having me.
Well, you're very welcome. We are very fortunate to have you as our leader. I am just really blessed, actually, to have you.
Thank you.
So let's just go ahead and proceed into this case. This is a 25-year-old young guy here in our ER that was brought in by ambulance. Now, in our emergency department, which is we're in a retirement community, the 25-year-old man is unusual, but...
Call the neonatal team.
Yeah, exactly. So he's 25. He comes in with altered mental status, right? So this is the quote that we get. Patient was found at the mall chasing cars and eating rocks.
Sounds like a good Saturday night to me.
Exactly. So it's funny, this case, I actually was in our white zone. I'm coming out of a room, and then nurse down the hallway looks at me and he goes, "Dr. Lee." And I'm looking down the hall, and there's like 6 guys in blue standing outside the room. So I know something is up. I'm like, can I say no? But the nurse was like, "Dr. Lee, don't you want to take this case?" Anyway, so I walked down over to the patient's room, and he's restrained. None of the medics are in the room, right? He's awake. He's in severe distress. He's very, very agitated, and he's restrained already by the security staff. And he's pulling at all 4 leather restraints. He's mumbling. He's grunting. He's spitting. So he's got this netting over his head, right? You can visualize this.
Absolutely.
Just looking at his exams, his skin is clammy, he's warm, his eyes are tightly pinched. He won't open them for me to examine it, but I managed to get enough to get a exam of his pupils and his conjunctiva. So he's tachycardic, his lungs are clear, he's just moving his arms symmetrically. He's bucking and he's fighting. He's really agitated, and he's grunting. Now, I say here grunting, and he's making karate vocalizations after provider introduces herself. Now, what that means is that I said, "I'm Dr. Lee," and after he heard me say that, he goes, "Oh yeah, oh yeah,
Oh, wax on.
I couldn't believe it. It was so funny that he looked at me, and then he started making these karate sounds.
So it has some lucency.
Yeah, or something. I wasn't insulted. I just thought it was hilarious, actually. So the EG course, it was 1512 when I first encountered him, and obviously he's so agitated. We needed to control him. We went ahead and gave him Haldo, IM, and then about 30 minutes later, as you see, or 23 minutes later, the patient's nurse said that he had quieted down. Okay. Just some of the studies we did. EKG was just what do you think?
It appears to be sinus tachycardia.
Yeah, everything there's no wide QRS. There's nothing particularly interesting about that EKG. So in a short while, his labs come back. We get a elevated white count. Anything else on there that you think is remarkable or interesting?
So his potassium's a little bit low, but nothing too exciting.
Right.
But his CK is elevated, so he certainly looks like he's undergoing some rhabdomyolysis, potentially from his combative state.
Sure, it makes sense, right? The guy is agitated as all get out. So then, we get the damning UDS.
Dun, dun, dun. Which is the first thing in a 25-year-old that we unfortunately turn to or suspect when you have a patient who's agitated coming in.
Yeah, so it makes sense. He's on meth, he's got cocaine, he's got THC. And the rest of the sort of routine tox labs which we check are negative. You know, the acetaminophen, the alcohol, aspirin's negative. Okay, so we're trucking along in this busy ER. We first see him at about 15:12. That's when he was totally agitated and combative. We get him calmed down with Haldol. Then now at 18:10, the nurse gives me an update and says that the patient actually woke up and said he did bath salts. And then he fell back to sleep. So then we're reevaluating him. I go back to talk to him. This is now 9 p.m. This is 6 hours after he gets to the ER. He is now really calm. We've unrestrained him during the time in the ER. He's oriented totally. He's got clear speech, talking to me. He's walking around. He says he doesn't remember anything that he did today, right? So I'm doing a little pushing and a little bit prodding, and he eventually did admit that he had used bath salts for the first time, right? So he supposedly didn't use any other drugs, even though he's got the damning UDS results. But he was really recovered so well that there was no reason really to put him in the hospital for anything else. Now, do you know much about bath salts?
I know a little, actually. My senior year of residency, I had to do a presentation on them to tox because they were just starting to come out at that time. And there was this transition from, we saw a lot of meth at the time, but they were seeing some components of ecstasy and heroin or cocaine. So they started doing a little bit more of a deeper dive into what was on the street at that time. And they discovered bath salts, ironically coming from the cot plant, and it was being imported, and it was huge, particularly in the Phoenix area. And they were seeing this huge, like you mentioned, this sympathomimetic toxidrome. Absolutely, that they just couldn't explain otherwise. And at that time, particularly, we didn't see it on drug screens a lot. It wasn't showing up under meth or ecstasy. So it was really dumbfounding for toxicology at that time for quite some time.
Well, that's the case, Mary Katherine. For my screencast, I really try to simplify what I want to teach with that particular case or that particular patient presentation. So I usually have 2 learning focuses, right? On this guy, the first learning focus, this is your brain.
On drugs.
And this is your brain on drugs.
Any questions?
Any questions? You remember
I remember those commercials. Wow, we're showing our age.
Yeah. So, in terms of bath salts, it's actually the active ingredient is mephedrone and MDPV. These are both derivatives of a plant from East Africa, and that may be that cat plant you were talking about. So both of these chemicals are structurally just like the methamphetamines that we see in the streets, the crystal meth. So mephedrone is more close to what a methamphetamine is, and then the MDPV is more close to ecstasy. And so essentially it's sympathomimetics, right? These bath salts are typically abused by insufflation, nasal insufflation, or ingestion, or maybe they'll do IV or IM or rectally. They come in these different various packages you can find on the internet. We'll go over the clinical effects. These are just your typical sort of sympathomimetic toxidrome manifestations, just like meth or cocaine or ecstasy. The euphoria usually lasts somewhere between 2 to 4 hours, and like meth, there's a very prominent, profound, long letdown period where they're just exhausted and are sleeping all the time, right? You've seen that.
Mm-hmm.
Yeah. The users have this compulsive dosing because they want that high, right? So they just continue to give themselves more and more and more. The complications of bath salts are just like any of your other sympathomimetics, right? there's seizures, there's severe agitation, you get myocarditis, chest pains. So you would treat a bath salt intoxicated patient just like any other sympathomimetic intoxication, right?
Absolutely.
Cocaine. But there's no utility in testing them except just to have the pleasure of saying, hey, you were on cocaine and you denied it. No. There is no antidote specifically for any of these agents, right?
Seems like most of toxicology, supportive care.
Yeah. Yeah, it seems to be. You have to treat the toxidromes. The specific physical manifestations you want to pay attention to and treat would be altermentation and sensorium, their agitation, the tachycardia, hypertension, their hyperthermia. And these are just very typical findings of the sympathomimetic patient. So the first learning focus is I just wanted us to be more familiar with the bath salts. It seems like there's tons of drugs out there and new ones every year. It's hard to keep up with all of this, but I think bath salts are still out there, and I think it's important to kind of refresh our understanding of it. That's my first learning focus. Next one, learning focus number 2. As I was looking up and reading more about bath salts, I came across this term, excited delirium. And it's really basically a very severe and potentially fatal form of the sympathomimetic toxidrome that we see. There's actually an ACEP white paper report that was published in 2009 on the excited delirium syndrome, and these are some of the quotes that I thought that would be helpful for us. Hyperthermia is a hallmark of excited delirium and a harbinger of death. My young man was not hyperthermic at all, but this is definitely something to pay attention to and remember, the hyperthermia. Patients are in a heightened emotional state with marked paranoia and mounting irrational fear.
And I think it's so important to have an idea of what you're going to do when you see this situation.
Yeah.
Because when patients come in and they're super agitated and amped up, security gets excited, the nurses get excited, and the whole mood or the temper in the room elevates very, very quickly, and everybody's immediate response is to fight him back, thinking they can control them, and you get this, what we call like superhuman strength. And all of a sudden this comes out, and all we're doing frequently is exacerbating the situation and causing this to get much worse, and potentially inducing a hyperthermic state. So it's so important to have an idea of what you're doing before you go into the room so that you remember to be calm. You have to be the most calm person in the room, and don't let others influence your decisions or how you treat the patient.
Oh, that's absolutely right. And the thing is, I've thought this for many years now, which is that the security folks don't know how to de-escalate, right? Have you had that experience?
Yes.
And I don't mean to
frequently
disparage them as much as that's just a reality. We see these sometimes part-time security or, sort of non-law enforcement staff. They don't really know how to de-escalate a situation like this, and what that winds up doing is actually increasing the combativeness, the hostility, agitation. And so you're absolutely right. As the physician, you have to maintain the calm and get the room's sort of vibration to go down. Go down if you can. Victims of excited delirium, usually they die from cardiopulmonary arrest.
That's the last thing I would have thought, in all honesty.
They die from cardiopulmonary arrest, and I thought this is fascinating. The proposed pathophys of the excited delirium is that there's an elevated level of synaptic dopamine when coupled with failed dopamine transporter function. This leads to agitation, paranoia, and violent behaviors, and this causes excited delirium syndrome. All that really says and means is that you have this heightened, out of control level of dopamine in your brain. The other factor that helps us understand the excited delirium and how it causes sudden cardiac death is the fact that the CNS dopamine level has so much to do with regulating your heart rate, your respiration, your core body temperature. And with this high toxic level of dopamine, it just throws your autonomic system completely out of whack, right? It causes tachycardia, tachypnea, hyperthermia, and ultimately that kind of dopamine storm results in death by life-threatening, generalized sympathetic storm within that autonomic nervous system, and it induces fatal arrhythmias. And that's the proposed pathophysiology for the sudden cardiac death in these excited delirium patients.
Makes sense.
Right? It makes sense.
Absolutely.
Total, right? Yeah. So the ACEP white paper report gives us a chart with suggested medications to use during these interactions in these cases. They suggest that the first line intervention is to use aggressive chemical sedation. I think that this is something we just naturally do, right? We get people, staff, security, hold them down, and we give them IV, whatever, or IM something. It's just naturally what we've taught.
I think the important thing to remember too is not only are we there to care for the patient, treat them medically, but we're also there to ensure their safety as well as the safety of the staff around us.
Correct.
So whatever we're going to do, it needs to be done quickly to control the patient, number one, so that safety is upheld. But number two, in the off chance that there's something else going on, it allows us to take control of the patient and get the workup that we need to,
absolutely. We have to
perform.
We have to restrain them for their own good. Another main approach to these patients is to make sure to institute your treatment concurrent with your evaluation. You can't do it, in tandem. You need to do it, restrain the patient as well as evaluating all at the same time, right? Whatever means used for physical control should aim to minimize the time spent struggling. So the least amount of time you're struggling with this patient, the better. So in other words, faster you get him calm, the better, right? So my guy, he was within minutes he was calm with that Haldo, which is good. And so I'm glad that I did it that way, and that is consistent with what the paper recommends. Now I think this last quote is really interesting and true, I think, in my clinical experience. Quote, physical struggle is a much greater contributor to catecholamine surge and metabolic acidosis than other causes of exertion or noxious stimulus or stimuli, unquote. So it's the physical struggle that I guess theoretically triggers them into this sort of toxic storm, Well, so we want to really totally restrain them physically, get them calm so that they're not fighting physically.
Well, it makes sense. If they're fighting physically, you're releasing those catecholamines, increasing that dopamine, and it's just
cranking it
further, it's starting this vicious cycle that they just can't get out of.
Right. It makes sense, right? Just totally
Absolutely.
Makes sense. And I thought, wow, this is good stuff. Can you think of a case of your own that you think that would demonstrate these principles or these?
So many come to mind.
Exactly.
Practicing in Center Phoenix.
Right, yeah. Oh, yeah, that's right, in your previous position.
Or in Kingman, meth capital of the world.
Meth capital of the world, yeah.
We saw this almost nightly.
Did you? Wow. How were you typically would approach these patients like?
I think initially when I was younger, I was scared to give medications because you're always concerned about the side effects. I had an attending once who used to use the term A to E, Ativan extinction, which just meant keep giving them more. Awesome. And when you're younger, you don't understand. You worry, you hear all these things. You're going to stop them breathing, or you're right. And from an emergency standpoint, there's no one we can't intubate. So,
absolutely,
I think as you progress and mature in your career, you feel more comfortable giving medications and giving higher doses, knowing, number one, that it's going to take high doses. So when you start getting questioned by the nurses, you really want to give 10 of Haldol. I remember when I was on rounds, what's the maximum dose of Haldol you can give? It's whatever your pharmacy has. You just keep doubling the dose just to keep them calm. So we used to see so many of these patients, and it was so true. The faster you get them down, the better. For multiple reasons. Number one, it's their safety, but number two, thinking outside the box too, you have a whole department to run. So you cannot divide or devote all of your attention to one particular patient. So the faster you get them down, number one, it's better for them, but it's also better for the rest of your patients.
Well, this paper definitely supports you. I guess I hadn't thought of it this way, but it makes sense, and so I'm going to definitely be more mindful of this approach and just get them down quickly. instead of giving them. I mean, I sometimes can be too patient with my patients, you know, and just give them a little too much time, which is odd because I'm not a patient person by my natural self. I'm very impatient and impulsive. But anyway, I've developed this patience with my my patients. But so I think I have, you know, practiced emergency medicine for 25 years, and so I've got obviously lots of cases. But I always think of this one case I had about 10 years ago, where there was a very, very agitated meth head, and he was 6'6", and he was 350 pounds, and it was one of the probably the most. I don't know if I was scared as much as just sort of heightened hypervigilant with him going into the room. And he became very agitated, stood up, kind of towered over me, and I was about 5 feet in front of him. The patient's nurse actually came up, standing next to me. He was very protective of me, and I appreciated that. But the charge nurse had already called the police. And so the police was within minutes away. I was standing there speaking calmly, trying to, you know, I'm only 5'4", right? Even with my shoes, I'm probably still very petite to these guys. And this guy's towering over me. The police comes around the corner, and he had a taser in his hand raised at this guy. And I was trying to calm the patient down. The patient said to the policeman, "You put that down, right? And I'll cooperate." And thank God the policeman actually was very wise to say, "Okay, I'll put this down, but you have to calm down. You know, you have to sit down."
You can see that escalating so quickly.
Exactly. So that's what I mean when I say some of the staff we have don't know how to de-escalate, right? Because we are, all of us, the nurse, myself, the police, we're all speaking calmly, coolly, and kind of trying to reason with this meth head. So it was just sort of this negotiation. It was very tense for a few minutes there, but to the policeman's credit, he did this very nice job of just talking and negotiating with the patient. So he sat down, and the police didn't have to tase him. And so I can't remember the rest of the case, but I just remember that interaction was like, oh, MG.
Well, it reminds you, you know, our natural tendency is to meet force with force.
Yeah,
you know,
exactly.
I'm going to show you who's boss.
Yeah.
And in reality, you know, I liken these patients to my 1 and 2 year old. There's no reasoning. Sometimes they still poop on the floor too.
Right.
But you know,
right.
there's absolutely no reasoning. So I give a little more to them than I would, you know, the typical patient. You know, you want something to eat? I'll give you a sandwich that was probably made within the last month in the fridge. You know, give them what they need to keep them calm to prevent any sort of escalation.
Yeah. I think that is excellent, and this paper does support that, trying to get them physically calm as fast as we can.
The one thing that I saw a paper similar to this, so there's a recent lecture, I believe, on MRAP about excited delirium. Ironically, when we first started talking about doing this lecture. And the one thing that I think is that I will actually change my practice based on this and that lecture is the medications that I use. You know, benzos, before the new antipsychotics came out, we relied a lot more on benzos, and I've always been an Ativan person. But reading these papers and listening to that lecture, they really talk about Versed and how much quicker it is and how much of a faster or a shorter half-life that it has. So it's faster on and faster off. And with most of these patients in these toxidromes, you know, ultimately what do we want is the patient to leave the department. So they actually are recommending more Versed use because the patient wakes up quicker and you're able to discharge them, as opposed to Ativan, you may have the patient in the department, or ultimately you're admitting them, and if you have a place that will accept it, you know, it's better. Otherwise, these patients end up sometimes staying in the department for 18, 24 hours, tying up some valuable resources.
Well, I hadn't heard that. Sorry, Mel. Not that I know him or anything, but...
Good day.
Well, Dr. Harper, that was the case. What do you think of that case?
It's fascinating.
Yeah. Well, I thought it was interesting because it really helps us get refamiliar with some of these drug abuse cases, patients. In the geriatrics ER, even though we see drug abuse cases, it's probably not as common as you would, let's say, in a downtown ER, or like downtown emergency department, where there's more of the community of the normal community versus our geriatrics. So for me, this was a case that stood out, and I thought it was just interesting to talk about and bring up these drugs and the management.
It's something like a tamponade or an aneurysm, dissecting aneurysm. You don't see them very often, but when you do, you need to know what to do, and very quickly.
Yeah. Well, in our ER, we see dissections pretty often.
It's true. So true.
The final words for this patient was, and for you listeners, don't do drugs, please, and don't fight with the police.
Drugs are bad.
Drugs are bad. Okay. Well, Mary Katherine, I have had a wonderful time talking with you. Thank you so much for joining me.
Thank you for having me.
Oh, you're very welcome.
My pleasure.
All right, very good. All right. So thanks everybody for listening and watching this screencast. Hopefully you've learned something, or it's refreshed your memory about bath salts and excited delirium. And we'll see you next time. Bye.
Bye-bye.